All right. Thanks, Amy. Good afternoon and welcome for those who are joining us for the first time. Thank you for joining us and welcome back for those who have joined us before. Thank you for joining us for our first session of the 2026 Year of Our Workforce Collaborative Training Series. Today, we're very excited to have Joey Rivett with us, MS-Ed CASAC-G, Program Director of Freedom Village Residential Rehab with Horizon Health with us for basics of schizophrenia. A few quick reminders. At the end of this session, we will be asking you to complete a very brief evaluation. Please take a moment to fill this out so we can continue to improve. We are finalizing details for our February session, so be on the lookout for registration information, which will be coming your way soon. We are always looking for new presenters, especially as we begin planning our 2026 calendar. We are interested in hearing what topics and speakers you would like to hear from. So if you're interested in doing a 1 hour presentation, or if you're interested in a particular topic, you can indicate that on your evaluation or reach out to Amy at amy.rockwood@erie.gov. The recording and slides from today's presentation will be posted to our website within the next few days. Just a reminder, the presentations and recordings from our past offerings are posted to our website as well. We have 5 years worth of amazing trainings posted. If you have new staff, have them check this out. If you're looking for information on a particular topic, we probably have that as well. Our training today is being recorded and everyone is muted. If you have questions, please put them in the chat. I will be monitoring the chat and Joy will be answering questions as we go along. And again, thank you all for joining us today. And I'd like to introduce Joey Rivett for the basics of schizophrenia. Thank you so much for joining us, Joey. It's all yours.
Thanks, Kathleen. So yeah, I've been with Horizon now over 20 years. I started back when I was in college studying to be a teenager. We had a day treatment program at Maine Amherst location, and we had a geriatric day treatment at the Holden location, which is now the Pathways Opiate Treatment Program. So that's where I kind of got my start. They said, "Oh, you want to be a teacher? You could run groups for, our clients." And it's kind of like running a classroom. And I walked in and I had no idea what I was getting into. So a lot of what I've learned over the years is just by experience. I thought I was going to be a history teacher, did that for a couple of years, couldn't stick. And Horizon called me, offered me a job as a case manager, came back. Eventually, I made my way to our pros program, which was on Bailey Kensington at the time. And as that, then they moved me to our continuing day treatment program back at Maine Amherst. So it's like back where I started. I did a few years there. And then sadly, a lot of the reimbursements were cut. And so they moved me to Horizon Village and Freedom Village. And they said, a lot of patients with severe mental health are being referred now to residential rehab. So we think you'd be a good fit there. And we are seeing more folks with those diagnoses now in substance use rehabs. So it's really important, even if you don't work, specifically with a certain population, to be prepared for anyone that walks in the door. So we've been able to take in more individuals with schizophrenia into our rehabs. So Freedom Village is interesting. It's got a chunk of veterans, older gentlemen, and individuals with bipolar or schizophrenia, and that's what we specialize in. So today I'm just going to go over the basics, the background. So the first thing is, well, how do we diagnose? So it's chronic. It's going to start typically before 25. It can happen. There have been cases at 30. If someone says they got diagnosed when they're older, that's possible. Maybe they just weren't diagnosed at the age it started and they've been living with it for a while. So you need 2 of the following features for at least 1 month and 1 of the first 3: delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, and negative symptoms. The psychosis doesn't have to be constant. There's got to be a social and occupational impairment. We'll talk about that. If the duration is less than 6 months, use schizophreniform. We really want to exclude drugs. A lot of times people get misdiagnosed because they're in drug withdrawals or they're doing drugs that cause them to hallucinate, be disorganized. So a lot of times I'll see schizophrenia on an application, I interview them, and it turns out that, someone gave them that diagnosis years ago, but they don't have it. We also want to rule out any medication that could cause it, medical issues. Once had someone with like a late stage syphilis that was causing some of these symptoms. So sometimes other things can cause them. And then the other key note is the individual does not return to premorbid level of functioning, so you're not going to see it in remission, right? It doesn't just go away. And if you stop taking meds, like, a lot of Americans do this. Hey, I feel better. I'm going to stop taking my meds now. Then the symptoms will come back. So it's really important when you meet with these individuals to keep checking on the medication. Don't just assume that they're going to always take medication the way you wouldn't assume any American's going to always take their medication, something a lot of people struggle with. Okay. So with schizophrenia, there's a lot to address, right? So there's the positive symptoms, and when I say positive, it means they're noticeable. You can see them. They're experiencing stimulus, hallucinations, delusions, disorganized speech and behavior. The medications have gotten a lot better at addressing these symptoms. Where the struggle tends to happen are the other 4 blocks in this slide, your negative symptoms. And again, that's less, not that it's a negative thing. Community functioning, lots of substance use, anxiety, and cognitive difficulty. So working in this field, those are the things that we can treat without that medical degree to write the script. And then we're going to have to cope then and teach skills how to cope with the delusions, hallucinations. So what I want to start with is, what might you see when someone walks in the door? I remember my first day at our Bailey Kensington Pros program. We had someone who, had glued CDs all over their coat and pants, and he had his sunglasses on in the waiting room. And just, of course, what are other people doing in the waiting room? They're looking at this guy, which then might reinforce his paranoia. So I always think of the song like I wear my sunglasses at night, like just a little different from the norm, right? A lot of times, a lot of my patients would really bundle up, like the lady in this picture. And on a day like this, of course, they're all going to come in bundled up. But usually when people go to group, they take their gloves off, they take their hat off. They might unzip their coat depending on, but usually our individuals would stay bundled up, keep the hat on, keep the gloves on. So one time I decided I was going to run group with my winter coat, hat, gloves, and kind of just model. And you get the, oh my gosh, what are you doing? I'm like, well, like, this is why we're teaching like basic social skills. Like, hey, when you're indoors, this is why you want to like take your hat and gloves off, because like people might look at you or think weird things and you don't want that. And you're having those thoughts about me running this group. So a lot of teaching too, and reinforcing. Sometimes these individuals will show up with stained clothing, ripped. And the first thing a good social worker would do is, okay, let's get you to the clothing closet and get you something better, something newer, something that fits. And often I compare it to like when you give your grandpa a new shirt to replace that 40-year-old shirt he wears to everything. You could buy it for him, he might not wear it, right? So sometimes even when we're trying to solve these problems, it's a battle. It's not something that someone's going to just dramatically improve day one. And that's what I really liked about our day programs when we'd see these individuals multiple days a week, is we could like track it, continue to reinforce, and then praise the positive changes. Sometimes there are issues with hygiene. So terms we'll use like malodorous, where that's where you notice it. So you'll sometimes see that in paperwork. Disheveled, messy hair, wrinkled clothes, might miss some spots shaving. Um, so then, like, I always ask people, like, what have you witnessed? And like, how do you have the talk? When we hear the talk, we think about, oh, how do I talk to my kids about sex? That's really uncomfortable, right? Well, I find clinicians find addressing hygiene very uncomfortable. They'd rather do a safety plan with someone with lethality sometimes than, address someone's hygiene or, the way they dress or what's going on there. So I always give like tips on how to do it. Um, so if you have any, put it in the chat. Some of the things I do, one is just to point it out. If you ask someone and they have schizophrenia, they might just say, I don't know what you're talking about. Um, and then we might look at it, in a residential rehab like mine, we might highlight in the schedule, like, oh, when can we work on our hygiene? When can we put laundry once a week? Remember, when we're going back to, oh, it's not one. Oh, I won't go back, but disorganized, right? Disorganized behavior is one of the symptoms. So if they're disorganized, it's your job to help organize them. So I'm going to highlight this day, this time for you to do this. Because if I tell you, well, just do your laundry once a week, that's not necessarily going to click, right? Um, and then when the changes are made, like, really positive reinforcement or, like, let me get you a coffee. And then that way they're like, people respond better to positive reinforcement in general. um and if they're really struggling despite a lot of interventions and what you're trying to do, that could also be an indication that maybe they need a referral to a residential program. Maybe they're not doing well on their own, or maybe they're with a family member, but that family member's not really helping them take care of them. So those are some things that you'll notice and see. Then there's boundaries in physical space. You might want to watch for the constant handshaking. We'll sometimes use inappropriate terms like friend or buddy. So I'll just remind them, like, I'm here to help you. Then my name's Joey, not Buddy. Sometimes things are misinterpreted as well. So I once got a patient a job somewhere, and after the first day, he's like, oh, the waitress, she's in love with me. And turned out she was just introducing herself and being friendly. So could definitely misinterpret some of that. But yeah, I remember my first day at our main Amherst program. I'm about ready to start group. We're sitting in a circle. The guy next to me just puts his hand on my upper thigh and starts talking to me. So sometimes it will be like the physically inappropriate, pretty direct, I've been kissed before against my will. Like sometimes those things will happen. I have a sense of humor about it. Like they're not, you got to remember, they're not trying to just manipulate you or take advantage of you. Sometimes they just lack that social awareness, and it's your job then to set the boundary, and so that they can succeed in the community. Um, you're gonna get a flight of ideas. A lot of speech. If you give them a worksheet, sometimes they will fill every part of the worksheet. So that's a notice. It could be some kind of mania going on there. Um, if you're running a group with this person, they might try to take over the group. So sometimes I'll like have them color while they're in group, and make sure they're not monopolizing. Sometimes you'll hear neologisms where that's an inventing of a word or phrase. So think of Snoop's famous "Fo shizzle my dizzle." Um, and I've had a lot of patients over the years that have created their own languages, words. It's really fascinating. So that's something you'll see as well.
One question that came in here, do they feel like they have to be thorough?
What do you mean by
That
thorough?
came from Katie. So Katie, I don't know if you want to chat and expand on that. Katie L.
Is that in relation to the last slide about filling in a worksheet?
She
Well,
said
yeah,
regarding.
that's just yeah,
Yeah.
that's like a just a certain thing. Of course, it's not everyone with the diagnosis, but when we go to like the disorganized speech or disorganized thinking, like you give a worksheet like 1 to 10, they'll fill out on the top, the bottom, maybe the other side, and um, you know, it could be very like overly detailed, overly thorough. So that's something, again, not everyone's going to have, but just some things to like notice, like, oh, maybe there's something going on here. And a lot of times, if they have schizophrenia versus bipolar, as it says at the bottom, there's really sometimes no theme. It's just random stuff. Whereas maybe the bipolar is writing about, the same thing. Um, can fill the page with notes that are not pertinent to the task. Yep, yep. And I enjoy reading. It's like it's a good kind of snapshot of what's going on with that person, or what they even know, what they're interested in. Okay. And then there's word salad. We're not going to see the video, but I always think about like it's like a toss salad. You're throwing everything around, so they're disorganized. The words are random. There's really no connection. So that's something that you'll notice. Perseveration, to me, the most famous example is Bubba Gump and his obsession with shrimp. So a lot of times these individuals will have a word or phrase or a topic they just beat to death. I had a guy who's just obsessed with cleanliness, which was kind of cool. Like, oh, what'd you do this week? I mopped the kitchen, and like started telling me how he used Dawn to, as his coping skill for the week. And, he just loved to talk about cleaning things. We also see this with autism and OCD. If you've ever watched the show Love on the Spectrum, right there, some of the people with autism on that show usually have like one thing they're really passionate about: trains, dinosaurs, whatever it is. And then they struggle with dating because that person that they're on the date with doesn't share that same passion, right? And this also happens with individuals with schizophrenia. They may be very passionate about a couple things, but then others aren't, and they don't read the social cues that others aren't as passionate. So sometimes in session, I'll have to like set time limits on a topic. Like we'll spend the first 5 minutes talking about superheroes or whatever it is you're really into before then we get to what we got to get into. Um, but you'll see perseveration on interesting topics. It's a great way to learn what they're into. But again, we got to set boundaries because they can talk, for the entire session if you let them. Um, Thought process. So the three ones you'll see are circumstantial, where they eventually get to the point, but they take a winding road. Tangential, they kind of relate, but then they don't get to the point. And then loose is just completely like, I don't know what they're talking about. This is not making sense at all. So one of the things I often tell people is I'll say like, start from the end. Tell me what you want. Try to refocus that person. Um, or just flat out say, whoa, 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 we're on the topic of this. Because sometimes in group, they can start on the point and then take it somewhere else. And it's your job to keep the group together. And, hey, we're on the topic of this. Let's go back to this. Um, so those are just some of the things I do. And again, like the more you work with the population, the more easier it becomes. I know sometimes when you're newer to this stuff, it's hard to just like butt in and take a group back. It's a lot harder for newer clinicians. This patient write a rap song for his counselor, and it really like demonstrates like the tangential and loose associations. And he wanted her to like rap to him. He had the beat ready and everything, and she's like, "No, can't do this." But as you can see, there's like guy's intelligent. He's got a knowledge of history, but it just doesn't connect. I wouldn't even know what to name this song. It just goes everywhere. Um, and so I thought like, oh, I'm going to use this in the training. This is kind of a perfect example of loose and tangential associations. You'll see a blunted and flat affect. So blunted is minimal expression, flat is more severe. And you are Saturday Night Live fans, that's Chad, who doesn't have much affect, and it's adorable to watch. And it's one of my favorite. I really like working with people with not a lot of expression, because then when they have that moment where they show some expression, it's like so rewarding when you see them happy, even if it's just for a moment. Yes, Chad was graded okay. We also hear clang association. So, I had this patient named Calvin. I'd be like, "What's up, Calvin?" He's like, "Shake a bake, a shake and bacon." And that was basically his way of saying, "Yeah, I'm good." Um, Fascinating guy. And then echolalia, they're repeating the end of the sentence. So whatever, it's often when you're running group, like at the end of every sentence, they may say the last two words, and which can be really funny depending on what last two words you say at the end of a sentence. So that's kind of what you'll hear. That's what you'll see. That's the language. That's the thought process. Now to the positive symptoms, the hallucinations and delusions. So we got audiovisual and other hallucinations. I had a patient that saw colors. So they were almost like clouding his vision in a way. Like he couldn't take the bus because he had trouble like even seeing right. Like he needed a cab to come pick him up. So like it affected what he could see. That's how strong they were. Sometimes people will report they see shadows, not people. And then there's of course the voices. So I always tell people, when people tell me they hear voices, what I want to know is it outside the head or inside the head? If it's outside the head, it's more likely psychosis. If it's inside the head, it's usually self-talk. Yeah, they're called positive symptoms because the patient is experiencing the symptoms. And they're noticeable, like I'm hearing things, I'm seeing things, or their delusions are I'm believing things. So they're just they're noticeable in that, and that's why I don't know who came up with the term positive. I wish they thought of a different word, but that's what it is. A lot of times patients will tell me they hear whispers, so they can't quite make it out. I had a patient who would hear music, and then he would sometimes start singing along in the middle of group, and I'd have to remind him not to sing in the middle of group. Tactile hallucinations, where you feel things. And then gustatory smell. I once had a patient have gustatory hallucinations of smoke, which was terrible because he always thought the building was on fire. So just imagine how much anxiety you would have if that was your hallucination. So very, very tough for him. Yeah, positive is an addition of symptom, negative something's missing, like that motivation, right?
Another question. What about people who hear music in white noise? I've read contradictory info if it's sensory or hallucination.
Yeah. I've never heard the white noise, but yeah, sometimes I had to wonder, and this will happen too. Sometimes you'll have people that um exaggerate their symptoms maybe for attention. Um, there is malingering where people fake having schizophrenia, maybe for disability or some other purpose, and then or some will have the diagnosis, but um, they like the attention. So my guy who was hearing music, maybe he just wanted a reason to start singing in group, and yeah, that's what's tough. That's why mental health in general is just that you can't just hold an X-ray to it. You know what I mean? You're relying a lot on their reports and history, and um, yeah, sometimes it's really difficult to tell. Like, are they hallucinating, or is there something else going, or do they have like tinnitus in there? I don't know. Gustatory hallucinations of rotting flesh. Ooh, that's tough. Oh, but it's very distracting. There's a video that I'm not going to show, but Anderson Cooper basically walks around with headphones and he's hearing voices, and they just have him do daily tasks. And he really struggles with just ordinary things. It's kind of putting him in an annoyed mood. He's kind of agitated. He's like trying to talk to a guy selling him a newspaper, and the voices are there. And so if you see someone like agitated, like they might be going through these perceptual disturbances. Um, Anosognosia is probably one of the most difficult parts of this illness. So the individual is basically unaware that they have this diagnosis. So it's not denial like like alcoholism, like, oh, I don't really have a problem. This person is basically unaware, you know, and then they're really hard to work with because like you can't just tell them that what you believe is a lie or is completely wrong. They truly believe it in their heart. So there's a great video about a guy who talks about it, and he says like he gives an example of like, imagine like you've been married 20 years and someone tells you it all wasn't real, it's all delusion, and if you go back to your wife's house tonight, there's going to be a restraining order because she's not your wife, she's someone you've been stalking several years. Like, imagine how that would feel, and that's their reality. um so that's a very difficult part to work with, and there's a whole method called the leap method. I'm working with that, where you want to partner with them and not challenge those beliefs, but build some rapport and see what you can agree on. And then over time, as they begin to trust you more, they might be more open to feedback and or get feedback from others, which again is a big reason why, I really think group therapy really works with these individuals, because they can learn from each other. Like, oh, I experienced that too, or oh, I used to feel that way when I wasn't taking meds. Because a lot of times when a professional tells them, it's easy to dismiss. When it's a peer, it's stronger. It's why we're using peers now more in outpatient in general. Grandiosity is a common delusion. So I usually, when someone thinks they're usually or has like goals that they're pursuing that are very high, often we'll like, well, what steps can we do to get there? If you just tell someone, well, you can't do that. So I always use the example of a guy who wanted to be a dolphin trainer. And it's like, okay, we got one aquarium. He has no experience, but he loves dolphins. All right, you know, maybe a first step would be like, working at PetSmart in the fish area, right? So sometimes this is how we work with these things is we're like, okay, let's break it down, because a lot of times people with this diagnosis will, they don't act in goal directed manners. Again, they're disorganized. Like, I want to be this. Okay, well, what do you got to do to be this? We got to start from the beginning. And that's how you could kind of support them in what they want to do without saying, well, no, you can't do that, right? Because then they're not going to want to come back to you. They're not going to want to tell you things. Delusions of control. So someone might think like there's an alien in them or a chip in them that's controlling them. So again, this is why we want to build a lot of rapport so that they tell us these things. Because a lot of times they've told this to somebody else and someone had a reaction. So they're often afraid to then tell their worker or helper. Delusions of guilt. So some people believe they're responsible for something awful that happened. So I had this one lady who, like, every time there was a hurricane, thought she was responsible, which was just a terrible thought, and it made her depressed. And then the sweetest thing was she says it in group, and they all tell her like, no, you're not responsible, and her peers were really supportive, and she said okay. So we often, like, when someone has these delusions, I'll have them like identify someone they trust, and then when something happens, like, talk to that person that you trust, and maybe they can then um help you figure out what's real and what's not.
A question that came in here. Why is it so common that people feel that the government is following them and talking to them?
Oh, okay. That's coming up in 2 slides, so I will hit that very soon.
Sounds good.
Okay, delusions of jealousy, um, must have little or no evidence. And then the persecution. So this gets to like the government, the mob, the CIA, the FBI, gangs are following me. Um, I think, it basically you have a belief, right? And then when there's some kind of psychosis, then it gets kind of distorted, right? So um and that's how I usually know it's like a delusion. Like, why would someone of this stature be following my person who's not doing really anything? Um, so it takes like thoughts you have in your head, and then they get distorted when an individual becomes paranoid. So if you have a thought that, oh, the government's spying on me, and a lot of people have that thought, not just those with schizophrenia. And then once that person starts having an increase of symptoms and anxiety, it just gets worse. Um, or it might start with something real, especially the gang one. Like maybe 10 years ago, they did owe a gang money and a gang was after them. So a lot of times I'll ask, well, when did it start? How are they following you now? What are they doing? And then when I hear like, oh, they're putting cameras in my windows, like no gang's going to do that. They're just going to come and beat you up or whatever. So that's how usually I can tell is like, what are they doing now?
A couple questions that came in. The first one here is, how do you differentiate delusions of guilt from OCD, where they have the obsessive thought that if they don't do XYZ, something bad will happen, like a natural disaster?
Um, I would I would think the OCD, like um when I've worked with delusions of guilt, they never think if they just do something different that it's going to change it. Whereas, like, remember, like, step on a crack, you'll break your mother's back. Like, so that's like kind of like the OCD is like, well, if I change this or do this, that it could prevent that. Where the delusion of guilt just like, oh, I did that off. That's terrible. I'm a bad person, or I'm being punished for something. Um, that's what I think. Um, it's a great question, though.
And then the second question here is, can taking certain substances, for example, stimulants, increase symptoms? And how do substances interact with schizophrenia?
Yeah, yeah. I do have a slide on marijuana, but just in general, right? So one of the reasons why these negative symptoms happen is it's the brain's way of like kind of protecting. So certain things get shut down because if they get too activated, then there's too much stimulus. So now if you're taking stimulants or even smoking a lot throughout the day, your symptoms are likely going to be worse. And of course, marijuana, if you're already predisposed to paranoia or you already hear voices, um, there are patients that have told me it helps them cope, but then there are those that say like you could literally tell when they start using again because their positive symptoms get worse. Um, so I often like now that over the years now we have stores that sell marijuana, right? So I'll often say like one, the marijuana is a lot more potent than it used to be. So if someone with schizophrenia smoked it 20 years ago, it might not impact their symptoms too much. Now it's a lot stronger. So even now it definitely does have more of an impact on individuals with these diagnoses and symptoms. And strongly advise against doing that. And it's like the same thing when, yes, alcohol's legal too, but if you drink and you have this diagnosis, your symptoms are likely going to get worse. Okay. And then we also I'll move on. Somatic delusions, what's that? So that's like a patient believes they have colon cancer despite there's evidence that they don't have it. Um, And so these patients I would spend a lot of time with them, especially when I was a case manager, because my job as a case manager was to keep them out of the hospital, keep them out of high cost care. Um, so they would often go to the hospital on a regular basis for very minor things. or beliefs, that delusions that they had. And I had this one lady who, like, they eventually started calling the police on her because they thought she was trespassing. Like, she's here like every day. Like, what do we do? And finally they got her in a mental health court, and then I became her case manager, and we worked on that. But yes, somatic delusions, very difficult, and or like it's hard to meet with them because there's always an ailment why they can't meet with you. There's erotomania, erotic delusions, so the belief that one is loved, so usually secretly by another person, often of higher status. So these are the most common names I hear. And even though Michael Jackson's dead, I had a patient that was dating him many years after his death. So these are how strong these delusions are, that even when the person publicly has died, that they just read that comment in the chat. Yeah, I wonder, like 10 years from now, if there's going to be a lot of Josh Allen's. And Rick James is from Buffalo, so I've had so many patients that have worked with Rick James. At least 5 or 6. And now with social media, it's becoming more real for them too, because what happens, someone like on Facebook, let's use Josh Allen as the example, likes a Josh Allen fan page. Well, some scammer is going to see that you liked it, and then they're going to reach out to you as Josh Allen. They'll use AI to distort their voice, and can really take advantage of everyday people, but especially the person with schizophrenia is going to have an even harder time, and be more likely taken advantage of with the way things are now. So I put Prince Harry on there. I had a guy who was in a relationship with Prince Harry, and I'm like, oh, how does the Prince of England reach out to you? He's like, oh, on Twitter. I'm like, oh, so definitely, like I always say, like have whoever you're meeting with, whatever their diet, have them like show you their Facebook page, show you what, if they have an online life, have them show you, because sometimes there could be some underlying things there. Okay. Twitch streamers have had a hard time with people having parasocial obsessions and people thinking that the streamer's in love with them because they say thank you to the stream donation. Oh, I don't know much about Twitch. I hear about it all the time. Then there's delusions of reference. So ordinary events have a special significance to me. So imagine a bowl of red M&Ms, a big bowl full of red M&Ms. Now imagine that there are some orange M&Ms scattered throughout the bowl. I would say your attention would naturally be drawn to the orange M&Ms. They would stick out. Now imagine this, the orange M&Ms are laid out in a way as such to spell your name. So the person with the delusion of reference thinks like, oh, this is a message to me, but then you look at the bowl and you just see some random orange M&Ms. Some other delusions, mind reading, thought broadcasting, belief that thoughts can escape your head. And the most common of these 3 I hear is thought insertion. Thoughts have been placed into my head by some person, group, or force. So when we're looking at these delusions, we want to think about, like, well, we got to look at religion, we got to look at culture, we got to look at anxiety, we got to look at politics. So, a lot of people without this diagnosis had some wild beliefs about the COVID vaccine. So when people learn about something that, are that's fascinating, like, oh, maybe there's this, that government conspiracy stuff, right? So when people like watch a video about a conspiracy, our brain releases dopamine, right? And that makes us feel good. And this is just my theory. What happens is we develop a tolerance, like drugs, to conspiracies, and so, like, we need to believe more crazier, outlandish things for our brain to get the same kind of stimulation. And so now what's happening is, everyone's on the internet, and people who used to have these conspiratorial beliefs used to be siloed, but now they're online. Everyone consumes it. And so now what may have looked like schizophrenia years ago, like we really have to do a good job of making sure, like, is this person just in a YouTube rabbit hole, or are they truly delusional? And it's very hard sometimes.
A question came in, or maybe more of a comment around the last discussion. I have a patient who has had a delusion of a local celebrity trying to break into their home. So that's pretty common then?
Yeah, yeah. And I always say, like, we're not going to convince them otherwise. Like I said, my lady that believed she was dating Michael Jackson, what wasn't, she had heard though that he died, but she doesn't believe that. So yeah, I don't know if I want to say the word common, but that is definitely a symptom. It also could be there are other diagnoses like delusional disorder, so maybe they don't have the other criteria of schizophrenia, but they have persistent delusions. And also with bipolar, that these things can happen too. They're not just exclusive to schizophrenia. Then we have the religious delusions. Worked with many people that said they were Jesus. Um, we want to just make sure we're not discriminating with, like, thinking because someone has extreme religious views, that doesn't really indicate a delusion. Usually I look for, is there an increase of preoccupation? Are they trying to evangelize me every time, I meet with them? Then I'm starting to worry more that it might be a delusion. Yeah, like met the girl behind the scam and still didn't believe it. Yeah. And that's the thing, even in the face of all evidence. And that's how you know it's a delusion, in the face of all evidence. It doesn't change. Okay, those negative symptoms that are taken away. So as I talked about before, it's a protective shutdown to prevent overstimulation. Negative symptoms are the hardest part of the illness, I find, because we can give meds for the positive symptoms. There aren't really meds in a way for the negative symptoms. So this is a lot of behavioral work and socialization. Um, and of course, when they get kind of stuck in a negative symptom maintenance loop. They're doing less things, which then isolates them more and makes them feel more depressed. And then it just, like, perpetuates and gets worse and worse. So some things you'll notice: a poverty of speech. They don't say much, or may just give yes and no. You could try to ask an open-ended question and you don't get much. Sometimes they'll just make noises. I had one patient, the goal was to use his words. He would often just grunt. Poverty of thought, often would say, I don't know. So sometimes I'll say, well, if you did know, what would you think? I often tell people, use a little silence, give them time. Sometimes they will open up. Motivation, struggles with severe anhedonia, likes to watch TV, fantasize about goals, but not move towards them. This impacts hygiene as well. We talked about the emotions. And then pleasure, because they're not doing much, they're prone to depression. It also, part of schizoaffective disorder has a depressive part. And then they're more apt to use a substance to feel pleasure. Someone put specific discussion routes if you go forward with trying to explain that this is not happening. Often, yeah, that's not the best route to go, really. It's to develop a rapport. And, first of all, is the delusion harming them? Sometimes it does. Like, I had a guy who, like, told me about his weekend, and he helped bury David Bowie when David Bowie died. And it was 10 minutes of him talking about it, and it was kind of funny. And, like, it was, like, nothing. If it's, or, I had my lady that was in love with Chris Brown. It was pretty hard. It wasn't impacting her life. So the first question was, how much is it impact? Are they, like, giving all their money to this person? Then it's impacting. And again, like, we definitely want to partner with them, build that rapport. And, like, we could ask questions like, when Michael Jackson, like, oh, I heard he died, like, you know, but we don't want to just challenge them because then they're going to get defensive and then they're going to stop seeing you. Um, and again, if we can get that person into more groups and do that kind of work, and we want to let our psych providers know they might just need to have their meds tinkered with too. Sometimes the delusions could go down when they're on the right meds. Is it bad to find some of the stories of delusions be humorous? Or it's just interesting. I never thought when I would do this work that I was going to be meeting people that told me these stories. And I like unusual behavior. um I grew up in a very, like, you got to be appropriate type of household. So when I would see you got to dress a certain way, my mother taught me how to iron at 8. So, like, one of the things I love about this population is it's so different. Like, I might hear something, I might see something that's not usual, and I like that part of it. It's just, but that's me. um One client struggled with negative symptoms to the point of being nonverbal in session. Yes, ask question about hobbies. Yeah, I had this one guy. I'll talk about it later. We would watch like a YouTube video the first 5 minutes of every session, and that would kind of start our session. Then that would get him to be talkative, or um, and I would do like strategies like that, and that's totally fine. Recreation deficits. So this is that social occupational withdrawal. The meds could really influence coordination. Um, they may be embarrassed or frustrated, or they're again, if you're hearing voices, you're not going to want to be around people and talk to people if you're already hearing things, right? Um, Watching TV is very easy to do. It doesn't take a lot of energy. So a lot of my guys will often just, I'll see them in front of the TV or YouTube a lot. And also lack of funds has a lot to do too. If our individuals don't have a lot of funds, then they can't go do social things.
Another question that came in here. If someone doesn't think that they have any sort of mental health disorder and they keep getting arrested, have burned all their bridges with family, refuse to link with treatment and medication, what can be done to help them see what's going on?
Sometimes I remember I would refer to the ACT team because the ACT team can go out to them. But yeah, it's, if someone's like, you're hoping that if they are getting arrested, that they get put in a treatment court. And if they can mandate treatment, that would really help. Um, Even if they're refusing, like, well, then you either, plead guilty to your charges or try this treatment court. And again, peers can really help with that too. Sometimes they'll listen to a peer or a recovery coach. But yeah, it's a challenge. Like, especially if one believes that the meds are harming them, that makes it very difficult. Um,
And, and
is it
one,
common to believe that people think television talks to them? Yes. And it's also why my bias is toward programming, right? So if someone doesn't have much going on and they have this diagnosis, to get away from the TV, come to this program, whether it's pros now, do a few groups, be around your peers, talk about things. And then typically what happens is then they're not then getting messages from the TV. Their symptoms are more manageable. They're seeing a psych provider on a regular basis. Okay. Relationship withdrawal. So most of my patients weren't married. I think, at one point we'd get 90 a day, and maybe 2 or 3 would be married out of 90 people. If you think about that, a lot of times, again, they're preoccupied with other egocentric ideas or fantasies, or maybe they feel alienated. So very few of the individuals I worked with would be in relationships. Occupational impairment. So only 14 to 20% of persons with schizophrenia hold competitive employment. There used to be a lot of shelter workshops where people would be paid for what was called piecework. So a lot of my people did that back in the day. A lot of those places have shut down. The movement is toward competitive employment, and sometimes that's good for a certain percentage, but for others, it's very, very stressful. Because once it's competitive, now you're being judged against others. So it's something like, again, if someone could meet the person out on the job site and meet with them after work, that certainly helps. And again, another barrier to competitive employment, again, is like the disorganization. So that's why I use the example of, let's start at PetSmart in the fish area before we're jumping into other things that are going to take tons of steps and a ton of time. People need wins, they need hope. And then again, like volunteer, might have to volunteer a little bit and build some skills, or go to a pros program and build on skills too.
A question, I know we're probably running a little short here, but a question came in the delusions similar to those of dementia. Someone had the example of their grandmother was in a car accident and was diagnosed with dementia. In the ER, she said that the doctors are trying to get information out of her and then claimed the pulse ox was draining information out. So not.
Yeah, and so dementia would be like the medical condition that would rule out schizophrenia. A lot of people I've worked with owe student loans because schizophrenia started when they were in college. So less likely to complete higher education. And there are programs to get student loans forgiven for individuals that got sick. Working at Freedom Village now, a lot of vets, develop schizophrenia in the service, and then that caused like a dishonorable discharge. So there are ways you can address those things now and get their discharge status changed. So that can really help too. We're gonna have to wrap up. So, I spoke about marijuana, definitely. The other concern is tobacco, 65 to 80% rate, very high. And again, smoking makes the meds less effective too. That's one thing I stress. And often, especially if the individual is older, they were told to smoke. They were given cigarettes. There were smoke rooms and day programs 20 years ago. And even now, it's like if you go to like a residential program, they may have a smoking area, and then that might be their only socialization for the day. So there's just a lot of reasons why individuals with these diagnoses smoke more. Again, those negative symptoms, being more bored, a lot more time. And again, not in relationships, right? Like I started smoking one time for like a week. My wife found out, threw it out, and that was the end, right? So sometimes relationships can really help us make the right choices. And then finally, how to help. You could do things in the treatment plan. I like to do daily or weekly goals. Again, we're helping people take steps. Build that rapport. Again, if someone's paranoid, they may not trust you. So we want to build a rapport. So one of the questions, and I try not to make my questions clinical. Do you ever hear someone talking to you that you can't see? That's better than, do you have auditory hallucinations? Do you hear voices, right? So sometimes people will experience watching TV and think they're getting messages. Does that ever happen to you? So those are just some ways. And then use humor too. Again, how do I build rapport with someone who is kind of iffy about coming into treatment? Like, we're going to joke a little bit. We're going to talk about what music you love. And that's really important. So where could I refer someone? Pros programs are really great. Besself has one. There's one in Lockport, the Dale Association. Community Missions owns one in Niagara Falls. But that at least helps people with structure if they're not working, or give them, coaching so that they can get into the workforce and see provider more often, because an outpatient, you might only see psych every few months, if that. I mentioned the ACT team. That's really good if they're struggling to link and have some hospitalizations and would benefit from someone coming out to them. I'm a big proponent of SPOA housing, DePaul, TSI, BFNC, community admissions, or SPOA applications online. But they get a residential counselor. Someone's going to check on them. Someone's going to make sure they're linking with doctors and treatment. And then finally, I'll add last slide. Our nurse, why he loves this population. I love working with them because they treat me like I'm famous. They're always happy to see me. They get excited to see me. I make a difference in their life. So when I worked in our day program, our busiest attendance day was Christmas Eve. That's when we get the most people, because we were family to them. A lot of family have shunned them or just aren't around. And so sometimes as you're the helper, you might be the most important person in their life. And that's what I love about this population too. And I got to the end.
Thank you so much, Joey. One question that came in here: are there interventions for tactile hallucinations? I had a client once really struggling with internal sensory stimuli.
I don't know for tactile. I don't want to give any wrong information.
All right. I don't see any other questions coming in here. So thank you so much, Joey. That was a great presentation and so much useful information that we can all use. Thank you, Amy, as always, for coordinating, and thank you all for participating today. Amy did post the link to our evaluation in the chat box, so we just ask you that you take a moment or two to complete that for us. And again, the recording and slides from today's presentation will be posted to our webpage, which is erie.gov/mental health. We will be sending out notices for our future sessions, but you can always check back to our website because all the announcements and registration links are posted there as well. If you're interested in being a presenter, if you have ideas of topics you'd like to learn more about, let us know. Again, thank you, Joey, for a great presentation.
Okay. Thank you all. Very interactive. I appreciate it.